This is the Pick Your Poison podcast. I'm your host, Dr. JP, and I'm here to share my passion for poisons in this interactive show. Will our patients survive this podcast? It's up to you and the choices you make. Our episode today is called Blue Mood. Want to know what the wet dog shakes have to do with humans? What drug reaction causes a temperature so high it can literally cook the proteins inside your body? What over-the-counter medicine can cause a potentially life-threatening reaction with SSRIs? Listen to find out. Today's episode starts in the emergency department. The intern presents the case of a 23-year-old woman with a fever, which started a few hours prior to arrival. The patient's had a few episodes of diarrhea, no vomiting, abdominal pain, or blood in the stools. She's had a mild cough for the past few days, though this is improving. And in addition, she says she feels shaky and jittery. The intern notes a past medical history of depression for which the patient takes fluoxetine, brand name Prozac in the U.S. She's also taking over-the-counter cough medicine, dextromethorphan, often brand named Robitussin here. He says the patient doesn't use tobacco, drinks 1 to 2 drinks per month, and occasionally uses marijuana. Her vitals are as follows: temperature 101.4 Fahrenheit or 38.5 Celsius, heart rate 125 beats per minute, blood pressure 120/80, respiratory rate 20 breaths per minute, and pulse ox 100% on room air. The intern reports the patient was shaky, but that the physical exam was unremarkable with clear lungs, a rapid but otherwise normal heart rate, and no abdominal tenderness. You ask if the patient has recently been on antibiotics or traveled outside the U.S., considering risk factors for bacterial diarrhea like E. coli or C. diff. The intern says no. He concludes by summarizing most likely a viral infection causing cough and diarrhea. He wants to check her lab work, a chest x-ray to rule out pneumonia, and a urine specimen to rule out urinary tract infection. The patient doesn't have symptoms particularly concerning for either, but you agree those tests are easy to obtain and therefore often done in patients presenting to the emergency department with fever. He's already ordered acetaminophen, aka Tylenol or paracetamol, depending where you live, and IV fluids. You agree with this plan, tell him you have a lot of sick patients to see first, and to let you know when the results are back. I'm going to share with you one thing we emergency medicine physicians wish everyone knew. The longer you have to wait to be seen, the less likely you are to be dying. Everyone hates waiting, understandably so. You'll have my full and immediate attention with no wait if you have a cardiac arrest, same with stroke, heart attack, a gunshot wound, stabbing, or a bad car accident. As painful as waiting is, and there are few people more impatient than myself, it's better to be in the category of people who wait in the emergency department than those who don't, for sure. Fever in a young, healthy person can be an emergency, but as we've talked about before, common things are common, and when you hear hoofbeats, you're supposed to think horses, not zebras. Common diagnoses would include viral infections, urinary tract infections, and appendicitis. We could talk for at least a week about fever, but fortunately, this isn't an infectious disease podcast, it's a toxicology podcast, so let's just skip everything else and focus on toxicological causes of fever, i.e. hyperthermia. Most of these are rare and difficult to diagnose. They are, in fact, zebras and not horses. And in order to diagnose them, you have to have a high level of clinical suspicion. If you don't think about including them on your list, you won't diagnose them at all. In most cases, also, they're diagnoses of exclusion, meaning you have to rule out infections and other problems first. Question number 1. Which of the following toxins can cause fever? A, MDMA, i.e. ecstasy or Molly. B, cocaine. C, aspirin. D, diphenhydramine, brand name Benadryl, or E, all of the above? The answer is E. All of the above can cause hyperthermia. Toxicologic hyperthermia occurs via different mechanisms, many of which we've touched on in other episodes. Aspirin and dinitrophenol, for example, uncouple oxidative phosphorylation or energy generation inside cells, meaning energy is released haphazardly, causing an elevated temperature. Diphenhydramine causes anticholinergic toxicity along with a number of other drugs and toxins. We'd expect an elevated heart rate, present here, but also high blood pressure, which she's lacking. Do you remember the mat as I had her mnemonic? Question number 2. If she has anticholinergic toxicity, her skin would be A, dry, or B, wet. The answer is A. She should be dry as a bone, which the intern denies. The sympathomimetic toxidrome also causes fever and tachycardia. It's from toxins like MDMA, cocaine, and methamphetamine. Again, we'd see an elevated blood pressure, missing here, and in this case, we'd expect a wet skin or diaphoresis. The resident says her skin is completely normal. Question number 3. Alcohol and benzodiazepine use disorders can cause a fever. Is it from A, overdose, or B, withdrawal? The answer is B, withdrawal. These are culprits. And the patient is shaky, which goes along with withdrawal. The intern said she drinks a few drinks a month and denied prescription drugs other than Prozac. You remind him patients can easily obtain benzos on the street in the black market, but you agree it's unlikely to be the cause of our patient's symptoms. You ask him if he thinks it could be serotonin syndrome or neuroleptic malignant syndrome. He gives you a blank look. Rather than pontificating, you decide it'd be better to examine the patient and discuss it in more detail with him afterwards. A few hours later, after treating sepsis, a pedestrian struck by a car, and someone with concerning chest pain, the intern flags you down with the patient's test results. The lab work, including a complete blood count or a CBC, as well as a Chem7 and electrolytes, is unremarkable. Her chest x-ray is normal. He asks about sending stool studies for C. diff and other infectious diarrhea. It's really overkill in this otherwise healthy patient without risk factors and only a few episodes of diarrhea so far. He says he discussed the lab results with the patient and asked her again for a urine specimen as soon as she can provide one. If anyone listening here has been a patient in the emergency department, can you please tell me why no one can ever urinate in the ED? I think myself and the nurses have spent at least half of our medical careers asking patients for urine specimens. Anyway, with your sick patient stabilized for now, you have a chance to go and examine her. The patient is sitting on the stretcher in a hospital gown with her knees pulled up to her chest, shivering. Your emergency department, like every other ED, seems to have a single temperature, freezing. As you enter, the nurse removes a thermometer from the patient's mouth. Temperature 102.2, she reports, snapping the machine closed. So the patient's temperature is increasing now to 39 degrees Celsius. How long ago did you give the Tylenol, you ask? 2 hours, the nurse answers. The patient's heart rate is still in the 120s despite the intern ordering a second liter of IV fluid. That might be the fever, though the acetaminophen should have kicked in by now. The patient gives you the same history she gave the intern. She asks about her lab results and seems surprised to hear they're normal. The intern mentioned already discussing them with her, but nevertheless, you review them again. You move on to the physical exam, agreeing with this heart, lung, and abdominal exam. Returning your stethoscope to your pocket, she asks you again about her lab results. Now you're becoming concerned about her mental status. Sure, patients don't always hear or understand things the first time we say them, but this is really perseverating. And the nurse says the patient's asked repeatedly for Tylenol despite having gotten the dose 2 hours ago. You continue your exam, now with fever and altered mental status in mind. You test her neck for meningismus, i.e. stiffness, thinking about meningitis. Her neck is supple and the patient denies headache and neck pain, which is reassuring. You check her cranial nerves, the nerves arising from the brainstem. Those are normal as well, then move on to her extremities. She has good strength and her sensation is intact. She continues to shiver, however, during your physical exam. Specifically in her case, it's shaking rather than a tremor. A tremor could go along with alcohol withdrawal or lithium toxicity. Patients with fever and chills get shaking. No doubt you've had this yourself during a viral illness. It's usually mild and usually you feel better when you get under the covers or a warm blanket, for example. When a patient has truly uncontrollable, severe whole body shivering, we call it rigors. And rigoring is often a sign of bacteremia or bacteria circulating in the bloodstream. So is that what she has? Well, it's possible, but an otherwise young and healthy person doesn't develop bacteremia and rigors out of nowhere. You watch her closely, noting the shaking starts in her head and moves down, like she's a wet dog shaking off water. She also has intermittent roving eye movements, like she's watching a disorganized tennis match. This is opsoclonus, which we talked about in the hitchhiker episode. It's a sign of severe neurological disease, or you guessed it, a toxin. Question number 4. This is a tough question, and it's more for the medical professionals. The wet dog shakes are associated with what? A, lithium toxicity, B, neuroleptic malignant syndrome, C, serotonin syndrome, or D, Parkinson's disease. The answer is A, serotonin syndrome. Lithium causes a tremor, not whole body shaking, same with Parkinson's. We'll come back to neuroleptic malignant syndrome in a few minutes. Wet dog shakes are a vivid description of an otherwise hard to describe and fairly subtle physical exam finding. It's almost pathognomonic for serotonin syndrome, meaning almost exclusively associated with it. It's also been called serotonin toxicity, which I think describes it more clearly for those who aren't familiar with it. It's essentially too much serotonin in the brain and the central nervous system, though the exact mechanism isn't really well understood. It can occur with toxins inhibiting serotonin reuptake, decreasing serotonin metabolism, or increasing its release, just to name a few. But again, exactly how it occurs is unclear. And to add to this, we don't actually know how many antidepressants work, including drugs like fluoxetine, a selective serotonin reuptake inhibitor, or as we call them, an SSRI for short. Originally, the belief was that increasing serotonin relieved depression. However, studies have since mostly disproven the correlation between serotonin levels and depression, so we're not entirely sure. Back to SSRIs like fluoxetine, i.e., Prozac. The reason is because they have relatively minimal side effects, especially in comparison with older generation antidepressants like tricyclics, for example, imipramine, and monoamine oxidase inhibitors like phenelzine. Not to mention, they're also much less lethal in overdose. Now, it is theoretically possible to develop serotonin syndrome from a single serotonergic drug like one SSRI, but in reality, it's actually quite rare. Typically, serotonin syndrome results from a combination of drugs or toxins. How do we test for serotonin syndrome? We can't. There's no test, and if you don't think about it, you'll never diagnose it. More on this in the next episode, where we'll discuss a famous lethal case of undiagnosed serotonin syndrome, one that changed internship and residency for every single physician in the United States. There are several different diagnostic criteria for serotonin syndrome. The most commonly used is the Hunter serotonin toxicity criteria. I don't want to belabor this. You can look up the specifics if you're interested. But essentially, you need a combination of the following: exposure to a serotonergic agent, along with some combination of fever, altered mental status, and muscle changes. Muscle changes include tremor, shaking, hyperreflexia, and clonus. Hyperreflexia is when you tap the patient's knee with a reflex hammer and the response is so sharp they almost kick you in the nose. Clonus is an extension of this when their leg continues to swing back and forth in a rhythmic fashion after just one tap. You ask the intern to join you at the bedside for a more thorough physical exam. You start to ask him a question at the bedside, then change your mind and tell him to step out instead. Good move, because when you ask him if he thinks this is neuroleptic malignant syndrome or serotonin syndrome, he says, is he the world's worst intern? Nope. This is actually a tough question, which can fool the best of us. Both of these conditions are frequently missed or misdiagnosed. I think we have enough information about our patient to make the distinction, but let me touch on the differences briefly because it can be confusing to clinicians at the bedside as well as to test takers on board exams. Neuroleptic malignant syndrome, or NMS, is a completely different disease, but it looks surprisingly similar, and it occurs in a similar patient cohort. It causes fever, altered mental status, and muscle changes. The issue isn't serotonin excess, but rather dopamine deficiency. Dopamine is essential for movement, and Parkinson's disease, in fact, is due to a lack of dopamine. If you don't have enough dopamine, you get rigidity. In NMS, this is called lead pipe or cogwheel rigidity. And when you try to move a patient's limb, it feels like there's resistance with every inch of movement, none of which is volitional. NMS can be caused by withdrawal of Parkinson's medicine, like if a patient suddenly stops taking L-Dopa. Neuroleptic is the old word for antipsychotics, and these medicines are by far the most common cause. It's not uncommon for patients with severe psychiatric disease to be on both SSRIs and antipsychotics. Patients with both syndromes can have severe altered mental status with agitation and even coma, so the history of exposure can be difficult to obtain or honestly completely lacking. So this is the reason we need to maintain a high level of suspicion if we're going to make the diagnosis of this zebra diagnosis. Both, as I mentioned, have fever and altered mental status. The key to differentiating them is two things: the timing and the muscle exam. Serotonin syndrome usually occurs within a day, often within hours. NMS, on the other hand, occurs more gradually over days or even a week. And as we said, serotonin syndrome causes hyperreflexia and clonus. In contrast, NMS causes rigidity. Back to the intern, you spare him further embarrassment by answering your own question and telling him you need a good muscle exam. He says, "I left my reflex hammer at home." You suppress a smile at remembering the reflex hammer you carried everywhere in medical school, now collecting dust in the back of your closet. "Use your stethoscope," you say. He has the patient sit up on the side of the bed and taps her knee with the bell of the stethoscope. She almost reflexively kicks him in the nose, and her leg swings for 8 counts. Positive clonus. We'll continue the workup and continue to rule out infectious causes, but we have enough to make a presumptive diagnosis and start treatment. She has exposure to serotonergic agents, more than one, fever, altered mental status, the wet dog shakes, and clonus. In my opinion, this is serotonin syndrome until proven otherwise. You discuss this concern with the patient, and she responds with, "What do you mean? I've been taking Prozac for 10 years without an issue." What do you think? That's question number 5. Did we make the wrong diagnosis? A, true. B, false. The answer is B, false. I don't think we're wrong. There is another serotonergic substance in her history. That's question number 6. Was it A, cough syrup, dextromethorphan, B, marijuana, or C, alcohol? The answer is A, dextromethorphan. Yes, cough syrup. The patient says she hasn't taken any dextromethorphan for 2 days since her cough was improving. What do you think now? Are we on the wrong track? Well, this information bothers me a bit. There is a case report or two of delayed onset serotonin syndrome, but typically, as I said, symptoms start within hours and almost always within a day. Still, her clinical picture is consistent, and serotonin syndrome is a serious, potentially lethal disease, so I wouldn't let it stop me from treating her. Question number 7, what is the treatment for serotonin syndrome? A, benzodiazepines like lorazepam or diazepam, i.e. Ativan or Valium. B, methylene blue. C, NAC, otherwise known as N-acetylcysteine. The answer is A, benzodiazepines. If you're a regular listener of the podcast, you've probably realized this is the right answer to almost every question. We toxicologists love to treat our patients with benzos. The hyperthermia in serotonin syndrome is likely due to excessive muscle activity producing heat. Therefore, sedatives like benzos are useful to counteract this. NAC is the treatment for acetaminophen toxicity, and if you said methylene blue, you just made the patient worse. You tell the intern to order an IV dose of benzodiazepines. It doesn't really matter which one. As I said, we often use lorazepam or diazepam. Treatment requires titrating the dose to the patient's symptoms, so we'll give a dose and then wait about 30 minutes or so to see her response. A few minutes later, the nurse walks into the doctor's station holding up a biohazard bag with a urine cup inside. She says, "We finally got a urine specimen. I wanted you to see what it looked like before I sent it to the lab. It's pretty hard to miss. The urine is bright blue." Unfortunately, we have to stop here for today. Listen to part 2 to find out the cause of this blue urine and what it means for our patient. If you've been listening to previous episodes, I bet you already know. This is a fictional case, as are all our cases, to protect the innocent, but next time we'll also discuss the very real and very tragic death of an 18-year-old woman from serotonin syndrome and how the repercussions of that case affected the medical training of every American intern and resident afterward. The last question in today's pop culture consult. In the 1990s and early 2000s, Prozac was featured in Time magazine, and references to it were found across genres in books, movies, and music. Which of the following didn't mention Prozac? A, American Psycho, B, South Park, C, Sex and the City, D, The Sopranos, or E, Breaking Bad? Follow the Twitter and Instagram feeds, both at PickPoison1 for the answer. Remember, never try anything on this podcast at home or anywhere else. Thanks for listening. It helps if you subscribe, leave reviews, and/or tell your friends. Transcripts are available at pickpoison.com. While I'm a real doctor, this podcast is fictional, meant for entertainment and educational purposes, not medical advice. If you have a medical problem, please see your primary care practitioner. Until next time, take care and stay safe.